All right. Good morning, everyone. My name is Prachi Kene. I'm a clinical psychologist by training, and I'm also a professor at Rhode Island College. And most of my research and clinical work has been in the field of suicidality. And this is a field that I feel very passionate about, and I'm excited to share what I have learned. And I want this session to be as interactive as possible. So feel free to chime in. Feel free to share your experiences, ask questions, or share your comments. All right. So we are. I think I'm kind of like a stickler when it comes to time. So it's 9:09. I think we'll take a break about like 10:30, 10:45. Is that okay? And I believe that we go for the second half, and then we'll wrap up by 12, 12:30. All right. So is that the timeline that you have been given also? I just want to make sure that we have the same timeline. Okay. All right. So what I'm going to talk today is about the scope of the suicide crisis, how significant it is in terms of being a public health issue, not just in the United States, but across the globe. We are going to talk about some of the advances in the field when it comes to suicide risk assessment, because there has been a lot of new information. And sometimes it can be hard to stay on top of the advances. We'll talk about that. And we will also talk about what are some factors that are necessary to minimize risk. All right. So this is from a global perspective. 800,000 people die by suicide each year, and that is more than homicide and war combined. Is anyone surprised to learn this? Because I think a lot of news emphasizes war and homicides and murders way more than deaths by suicide. And we have to keep in mind that these are reported deaths. So it is very likely that there are a lot of people who, whether deaths go unreported or they are reported as accidental overdose and things like that. Just give me 1 second. Just 1 second. All right. Sorry about that. So if you look at the numbers, suicide accounts for 1.4% of deaths worldwide, and it is the 15th leading cause of death. When we look at these numbers, we have to keep in mind that not everyone uses like the same recording system. Like not all countries do psychological autopsies. Like not all countries like monitor like deaths. Like some accidents, like car accidents could actually be suicidal deaths, but they're classified as accidents. And one person across the globe dies by suicide every 40 seconds. And for each adult that dies, 20 others attempt suicide. And the rate is much higher for men than it is for women. And can someone guess why that would be the case? Like why more men die by suicide than women, generally speaking?
I think from my perspective, it's because we don't share our emotions, and society has made us to believe men don't cry and those kind of stereotypes.
Absolutely. I mean, that's definitely one factor is that men, like it is socially more acceptable for a man, for a woman, sorry, to express feelings or to seek mental health treatment, right? Can you think of some other factors? Say, thank you for sharing that, Billy.
I've heard that maybe men choose more lethal techniques compared to women. So there is a greater chance of death if you choose something more lethal.
Absolutely. So men are more likely to use firearms, especially in the United States, versus women are more likely to. Do you know what's the most common method women use? Overdose. And you're more likely to survive an overdose than you are to survive a gunshot wound. So, yes, absolutely. And in the last 45 years, the rates have risen by 60%. Can anyone guess like what would be some factors that have contributed to that? Like why are more and more people dying by suicide?
Well, one of the reasons may be like societal pressures. Like I know a lot of people don't feel like they're good enough, look good enough, do anything good enough, and they use all of that pressure, and it eventually may lead them to do attempting suicide. because they don't feel good enough for society.
Absolutely. And I think social media probably plays a role. How many of you are on social media? Just by a show of hands. And how many of you, like, when you go on social media, like, end up feeling good about yourself? I don't see anyone raising their hand. So, I mean, I think like Facebook, I'm not a social media person. And part of that is because my family's on social media all the time. But like my family, meaning my parents and my sister. But like social media has been, like there's like some discussion about how social media probably has played a role in some of these issues. That and like people more and more of us struggle with like self-esteem issues, self-worth issues. And if you think about war, like if you like right now, more veterans die by suicide than they do in active combat. Did you know that? And one of the reasons for that is, can you guess why? Well, why do you think, some potential hypotheses? Why would veterans be dying from
If I had to take a guess, I would say maybe like PTSD, mental health concerns, things like that nature.
Absolutely, yeah. And I also think, yes, PTSD, there's a lot of substance use amongst mental health amongst military, amongst like veterans. And also, if you think about it, more veterans are surviving combat than they have before. All right. And then they come home back to civilian life, and it's a really tough adjustment. So if you look at the world map, this is from 2014 and the data are always being updated. But if you see the darker the color, the higher is the rate of suicide. And as you will see here, that there are countries that are like red that have a much higher rate. So you see parts of Southeast Asia, you see parts of East Africa, and then the orange, like United States, kind of like also has pretty high rate on the higher side for sure. And these are data on the United States. Most recently, 48,000 people, over 48,000 people died by suicide. We have to keep in mind that the opioid epidemic probably has played a huge role in some of this. One person dies in the United States every 12.3 minutes and one attempt every 30 seconds. And not too long back, suicide used to be the 11th leading cause of death, and now it is the 10th leading cause of death. I teach at RIC, and we are extremely concerned that among students, it is the second leading cause of death in ages 15 to 24. And of all the states, Rhode Island ranks 45th. So we do fairly well as compared to some of the other states. And the most common methods that are used are firearms, suffocation, hanging, and poisoning. Any reactions, any questions about this? Are you surprised by any of the data?
It's just a lot more than I thought of, you know? Like you think it's high, but then when you finally read the statistics, you realize it's a lot higher than you thought.
Yeah, it's very disturbing, right? It's a very, I mean, if you think about it, I mean, right now, you know, the pandemic is a bigger issue, but if you think about like the funding, like the dollar amount that goes to like cancer research versus suicide research, there's a lot of discrepancy there. I'm not saying that cancer is not like something that deserves to be, does not deserve to be researched, but the proportion of people that die by suicide versus people that die by cancer, and the amount of the amount of monies that are invested in the research areas, you will see a significant discrepancy there. So this is the CDC map for the United States. Once again, the darker the shade, you will see the darker the color, the higher is the rate. And so you will see like Alaska, for instance, has like some of the highest rates of suicide. Compared to like the Northeast or like the New England region. Anyone surprised by this? And I know gun ownership.
Question about
Yes.
the map, like, is there any correlation with like with the suicide, like with finance, because some of these states are ranked financially. These are some of the more like substantial states. So is there any correlation or reason in particular why certain regions have a higher suicide rate?
That's a really good question. If I understand correctly, the question is there a correlation between like the financial circumstances of the state and the suicide rate? Is that correct?
Yeah.
Yes. So yes, there definitely is a relationship. I don't think it is a perfect relationship. So because there are a lot of factors that play a role. As we'll see in the next slide, like one of the factors, poverty is something that is correlated with suicide, but it doesn't have to be the only predictor. One of the factors that actually is a better predictor, if anyone had to guess, would be state laws about gun ownership, how permissive the state laws are. Does that make sense? I have lived in Kansas. Anyone in here that has lived out of the state? Yeah.
I lived in Florida for a little bit.
Yeah, Florida. Okay. Anyone else? Typically people in Rhode Island are from Rhode Island.
Well, I came originally from Ghana, and then I went to college in New Jersey. So.
Oh, that's really cool. How old were you when you came here?
I was 14 when I came here.
Oh, wow, that's really cool. I grew up in India, and I came to the United States too. So yeah, it's an interesting experience for sure. Yeah.
Prachi, I just wanted to make a connection to the map that I'm noticing. So in the chat, James said that states where there's nothing to do are higher. And also you mentioned gun ownership, and I'm looking at Idaho. I've been to Idaho before, and their gun laws are very like liberal, and I noticed as red as well.
Yes, and I just opened the chat section. Yes, yes, economic hardship plays a role. Gun ownership plays a role. So think about it, like when people are in a suicidal crisis, having easy access to guns, having easy access to lethal means is going to play a huge role. Does that make sense? And is that kind of like the question that you were asking, Deb?
No, it wasn't necessarily a question. I was just tying it together, like everything that was being said, like in the chat, what you said, and then I was looking at the map, and it's like, well, there's nothing. When I went to Idaho, I noticed that there isn't much to do. It's like the woods, basically. So that coupled with gun ownership being so liberal, I can understand why it's so high.
Yes, absolutely. And also like gun ownership and guns could be a part of the lifestyle where people go hunting more frequently and things like that. And that could also play a huge role. So I lived in Kansas. I don't know why. I lived there. I lived in a town called Pittsburgh, Kansas. It's like a town with 10,000 people. And to have fun, I would go to Walmart. Like that was like the only thing I could do to entertain myself, to just like walk around the aisles, because there was nothing else to do. And like hunting was a big part of people's lifestyle. Like that was, and hence there were like a lot of like gun ownership. Like gun ownership was pretty easy. So if you look at this next chart here, what you will see is like, if we were to draw a line through these bubbles, all right, you will almost see like a straight line. All right. And what this basically indicates is that the rate of suicide is much, much higher in states that have permissive laws about gun ownership. All right. And this applies not only to the United States, but this applies to other countries also, where laws about, for example, in countries like India, Sri Lanka, Nepal, where the predominant way of ending your life is by ingesting pesticides, these are predominantly agricultural countries. In like states that allow more access to pesticides tend to have much higher rates. All right, so we have to kind of look at that. And I know like gun ownership is a very political issue in the United States, but the data are very clear. Having access to lethal means, like having easy access to lethal means, increases the chances of dying by suicide. And you will see Rhode Island, you will see it in the bottom left. Do you see it like Rhode Island, Massachusetts, New Jersey? I know, Willie, you said that you lived in New Jersey, DC, Connecticut, California, and Maryland. So those are the states that tend to have more stringent laws about gun ownership. So what's the problem? with suicide risk assessment. Let me ask you this: how often do you you work with a client that is at elevated risk, and what are some issues that you encounter? Underreporting, yes, absolutely. Emma said that underreporting is an issue. And can you see why people would underreport? Yeah. Has anyone in here been on a locked unit, psychiatric unit ever? Okay, I see some people raise their hands. Yes, I appreciate you sharing that. And for people who have been on a locked unit or have reported suicidality and don't feel like you have to share anything that you don't feel comfortable with, can you see like what would be some reasons like not to disclose to anyone?
Yeah. I mean, I'll disclose. I was inpatient at Butler Hospital when I was about 17, and you know, some people that I was able to introduce myself in there, um, they said that they were feeling depressed and what have you, but what got them sent into inpatient and now they were like overly watched was saying that they had suicidal ideations or wanted to possibly commit suicide or harm themselves or others. So as soon as they were admitted, you know, they were like constantly observed, like somebody was watching them over their shoulder, and then they just couldn't feel like they could breathe. So like they kind of regretted saying it because they were like, I don't necessarily want to kill myself. I just felt that way, and then it ended up turning into them being evaluated constantly, and they just regretted it.
Yeah, yeah, yeah. Yeah. I mean, I think about if I were in a crisis, the last thing I would want to do is be on a cold psychiatric unit, right? I would want to be next to my dog. I would want to be next to my baby. I would want to have a cup of hot chocolate, be able to watch Netflix, right? And the last thing I would want to do is be in a locked psych unit. So yes, like Emma reported, underreporting is an issue. Also, like what are some other issues that you encounter when you are doing a risk assessment or when you do work with someone that is at elevated risk?
To me, it will be most of the time the client will disclose information to you that don't want you to disclose with anyone. So it's like I'm stuck in between. Do I ruin the bond or the relationship I just built to make sure he or she is safe or keep that? But most of the time, I tend to disclose it either ways because their safety is what we want most of the time.
Absolutely. I think that's a great point, is where you have a client that is confiding in you, right, about something, and they feel how do you maintain the therapeutic relationship while you still have like an obligation to report that, right? I mean, that can be a big issue. Thank you for sharing that, Billy. Yes. What about the fact that a lot of us at some point in our time, at some point in our life, might think, you know what, fuck this, I can't deal with life.
Yeah, I don't know about anybody else, but I felt that way myself.
Yeah. Yeah. I mean, a few weeks back, my car, like when we had like one of the bigger snowstorms, and I had an old car back then, like such a beat up car. I was surprised that it was moving at all. But it was like, it wouldn't start up. And then I called the AAA guy. The AAA guy could not start it up and things like that. And I was like, you know what? Just fuck this shit. Like, you know what? I can't deal with this. I'm just going to watch Netflix today. I'm not going to try to do anything. So the issue is that a lot of people, I'm not saying I had suicidal thoughts in response to my car not starting, but I had this like sense of hopelessness, right? And a lot of people feel hopeless. A lot of people feel that, okay, they cannot keep going on with their life, right? And that does not necessarily mean that they're going to act on the thought. So what basically looking are like identifying, trying to detect people who are at elevated risk is basically looking for a needle in a haystack. So if you think about this, a large number of people think about suicide, a really small subsection of those people act on that thought, and an even smaller subsection actually complete the action, All right. So but basically what we have is a large number of false positives, which basically means that everyone that tells us that they're elevated risk, we're likely to say, oh my God, this person is at elevated risk. Does that make sense? And that's basically, we're providing intensive treatment to someone who may or may not benefit from the treatment, or who may or may not need that treatment. Most people who present these risk factors, like if you go by risk factors alone, like what are some risk factors that you're aware of for suicidality? Being a Caucasian male about the age of 60, 65 is a risk factor. But if I'm working with, let's say, a 24-year-old African-American female, does that mean that she's not necessarily at risk? Absolutely not, right? So, so basically what we are doing is when we are looking at risk factors, we have to look at them as not as sole factors that help us make decisions. We have to look at them as red flags, all right? So if you are working with a veteran who says that I've never had thoughts of ending my life, that's a red flag. Does that make sense? So I wouldn't use the risk factors as sole factors to make decisions. If you have your smartphones on you, does everyone have smartphones now? Yeah. All right. So what I'm going to have you Google is like, think about any risk factor, all right, and suicide. Just like Google anything and suicide. And you will find some information about it. Does anyone want to share what they Googled and what they found?
It says, well, from what I got, it says family history, history of alcohol and substance abuse,
Right. Absolutely.
hopelessness,
Yes.
impulsive or aggressive tendencies,
Yeah. Yeah.
history of mental disorders.
Yeah. And how many people, like impulsive people, would never even think about suicide? Right.
Yeah, there's a lot of list over here.
Like if you Google religion and suicide, like if you Google shoes and suicide, you will still find information about it.
Oh yeah.
Mine was actually interesting. I googled financial status and suicide, and there was a new study that came out that said people who have recently experienced severe financial strain have a 20-fold higher risk of attempting suicide than those who don't have that risk. That's kind of a lot.
Yeah, yeah, yeah. And you have to look at that in the context of the pandemic and things like that. Yeah. So can you see, like, there is research on just about any risk factor when it comes to suicide, and basically having a risk factor does not necessarily mean that someone is going to die by suicide. So what does the latest research indicate? That we have to focus on the transition from ideation to attempt. What causes people to go from thinking about suicide to wanting to die, from like thinking that I want to end my life to planning to engaging in behaviors, right? Does that make sense? So like for the longest time in the field of mental health, we are focused on who's thinking about suicide. But that's a very problematic framework, because a lot of people think about suicide, and what we really want to focus on who's actually going to engage in those behaviors. All right. So moving forward, do you quickly want to watch a funny video? You look like you could watch funny videos right now. All right, let's just quickly watch. I know this is being recorded, but
let me know if you need any help, Prachi.
Okay, thank you. Is it okay to show them a funny video?
Of course. I bet it'll be much appreciated as well.
Okay, so I'm a dog person, and we're going to watch this video of Denver the Guilty Dog. Can you see my screen, YouTube? Just a couple minutes, it will probably play a commercial.
Research shows this can help you remember ads. So, customize and save with Liberty Mutual.
All right, well, apparently while I was out, somebody got into the kitty cat treats. Now, I'm gonna go look at the suspects. Suspect number one. Is it you, Macy? See your face. Did you do this? Did you? I don't think you did. Number two. What? Did you do this? Denver, did you do this? Denver, was this you? Denver, you won't look at me. Did you? What? Denver, did you do this? Look at me. Come here. Let me see. Let me see your face. Oh my goodness, Denver, you didn't. You did this? What? You got into kitty cat's treats while I was gone? I can't believe it. Are you sorry about it? Okay. You know the routine. In the kennel. Oh. Very disappointed. You're in the penalty box. You let it happen. I hope you're happy too.
All right, so now that I have everyone's attention,
Hey, do you want to?
let's focus on the theoretical models. I said like one of the biggest transitions that has happened in the field is in the past we would have this like haphazard understanding of like what is causing suicidality, but now we are trying to understand more about like, wait a minute, what is causing people? Like the first change that has been, what causes people from thinking about suicide to actually acting on those thoughts? And that could be different for different people, right? Like for some people that could take 5 minutes. For some people could have planned that for years, right? Is that possible? That the transition from ideation to attempt could be different for different people? Is that possible? Yeah. So, well, what do you think in your mind? Like, what do you think causes people to go from thinking about it to acting on it?
It's just quiet, so I really don't know, but I would just say like the hopelessness, like if the same situation continues with no change, and they haven't reached out for any help or no one's asked them for any help, maybe that's where it just goes from just a thought to actually wanting to act out on it.
Yeah. So kind of like feeling helpless or powerless over the circumstances. Situation's not changing. Yeah, absolutely. That could be a good point. Like somebody that is in an abusive relationship, right? Yeah. Anything else? What about having access to lethal means? Is that possible? Yeah. So like when we look at suicidality, the focus has been on understanding who is going to think about suicide. All right. Who is going to think about suicide? People are feeling depressed. People are feeling hopeless, like you said, like you identified. Remind me your name again.
Odessa.
Okay, thank you, Odessa. Like people who are feeling hopeless, people are feeling that circumstances are not changing, are people more likely to think about ending their life. And then there is a subgroup of people who go from thinking about suicide to actually engaging in those behaviors. So one of the models that like has really changed the trajectory of my professional life is the acquired capability for suicide. And it is called the interpersonal psychological theory of suicide. And it proposes 3 different constructs, all right? And we're going to talk about this at length today. It says that people die by suicide because they can and because they want to kill themselves. What do you think about this? Because they can. Like how many of you, like if I said, okay, you don't have to sit through this training if you can like go bungee jumping?
Well, I'm not bungee jumping, but the option is there. It's the, you have that freedom, that free will to
Right.
make those choices.
I see Michaela mentioned that no one wants to kill themselves. I think that is a really good point, that we by nature really want to preserve ourselves, right? It's a very basic instinct for self-preservation. We want to keep going on, we want to live, we want to evolve. People, so basically what this model says, if you look at the figure on the right, you will see that there is a big blue circle, which says that who wants to die by suicide. That is, people who want to die by suicide are people who perceive themselves as a burden on other people, that I feel that I'm such a burden on other people, that my family and friends would be better off without me. And it also includes people who think that I don't really belong to a group of people. I don't really belong to, like I don't really have my tribe. Like those are the people who think about ending their life. But then the yellow circle, if you look at the circle on the right, are people who have the capacity to kill themselves, right? Like people who get multiple tattoos, people who have had multiple surgeries, people who can go like drive like 140 miles per hour and things like that. So, and there is nothing wrong with getting tattoos. Like I'm not saying there's anything wrong with getting tattoos or multiple piercings and things like that. But it is the region that is red in the middle. Those are the people who both have the desire to die and who also have the capacity to die. Does that make sense? And those are the people who are at the highest risk to die by suicide. All right, and we'll talk more about this. So without sensationalizing the whole topic, I guess what I'm trying to say is that people die by suicide because not only because they want to, but also because they have the prerequisite knowledge and skills to do that. Does that make sense? And I know that can be pretty disturbing to you. I'm curious what your initial reactions are to me saying that. You're probably still digesting the information. So let's look at this. So the key 3 constructs, let's take a closer look at those. Okay, so failed belongingness, this kind of like stands out in suicide notes, is the individual's perception of not belonging, the individual's perception that I don't really belong. So you could have 1,000 friends on Facebook, but you could still feel that I'm pretty isolated, I'm lonely, I don't really have a relationship. And the perceived burdensomeness is a feeling of being ineffective, feeling that I cannot pull my own weight or I'm not doing my share. And that if I die, people will be better off. Like my death will be worth more than my life to my family and friends. And this is also something that pops up in suicide notes, is like, I'm leaving so that you don't have to worry about me. Your life will be much simpler without me. Now, on the second hand, the acquired capability for suicide, let's talk about this in more detail before I pose that question. So for people to engage in lethal self-injury, for someone to be able to end their life, they have to be habituated to fear and pain. Does that make sense? Like, how many of you can watch Texas Chainsaw Massacre, all right, and eat a bag of popcorn along with that? Okay, I see one person raise their hand. How many people? I'm just going to scroll. Can you raise your hands if you can do that? Okay, 2 people. I see that. Anyone else? Anyone on the first screen? I know you don't know what screen you're on. Anyone? Again, can you raise your hands if you can watch Texas Chainsaw Massacre and eat a bag of popcorn? People are saying no. All right. Okay, James, I can see you raise your hand. I appreciate that. So what that basically means is that we basically there are certain experiences that cause us to become habituated to fear and pain associated with self-injury. Do you have any clients that engage in self-injury on your caseload right now?
Yeah.
Okay. And what kind of self-injury that do they engage in?
So again, some use shaving stick. There's a blade in it. I never knew that, but some use that to cut themselves. And then also others try plastic knife to see how that would be. So yeah, and some of them, I don't know, scratch their face and eat their nails like
Yeah.
it. Yeah.
Yeah. So like basically, I mean that kind of. So in that situation, most of the times the intention is not to die. The intention is actually to relieve the pain, right? It might actually make the person feel better in the moment. So yeah, and have you seen like do you like? Thank you for sharing that, Willie. Anyone else on here like work with clients that engage in other forms of self-injury?
Yeah,
Oh.
I've seen clients either do like art not very deep, but like artificial cutting on their leg or their wrist. But other than that, I haven't seen any other forms of attempting.
So I have had a client in the past that bangs his head on the floor, and to me that was the craziest thing I've ever seen. Like,
Yeah. And can you think about if that person had the urge to end their life, let's say, okay, Willie, thank you for sharing that. Devin, thank you for sharing that. Can you see how like these people would be at a much higher risk than someone that does not engage in those behaviors? All right. So what I'm basically trying to say is that we all try to avoid, from an evolutionary perspective, we avoid feeling fear and pain. But there are certain kinds of experiences that cause our fear of self-injury, that cause a decrease in a fear of our self-injury, and they cause desensitization to pain. Anyone in here that has gone like bungee jumping or like an amusement park, the first time you go on a ride, you're like terrified, but the second time you do it, it's not that bad. Has anyone had that happen? Yeah, and that's the exact principle that I'm talking about, is that there are certain experiences that cause us to become habituated to pain and provocation. And what that basically does is this in turn causes our basic instinct of self-preservation to weaken, and the person is more likely to engage in lethal self-injury. Can you think of some experiences, without me going on the slide, what would be kind of the experiences that would cause people to be less fearful of physical pain and provocation? Willie and Devin kind of like identified kind of like the self-injury, like cutting or head banging. What would be some other experiences?
I had a client that used to binge eat to the point where she would almost explode and have to go to the hospital that way. But each and every time she used to say like, oh, I hope this is it. I hope I just had so much in my system. This is it. But that for me was kind of strange. It was like a more slow, I don't know how to say this right, but not effective way of going about it. But she used to put herself in so much pain and she wanted the pain.
Yeah, I think that's a very good example, Laura. Thank you for sharing that. I mean, people with eating disorders, definitely, like there could be like binge eating, there could be using laxatives, there could be a food restriction to the point that people are starving, or excessive exercise. I mean, that's definitely a great example of someone who would be tolerating a lot of pain. Thank you for sharing that. Any other examples? So some of the other examples would be being a victim of assault, injury from recklessness or substance use. Like think about people who drink a lot of alcohol or who use a lot of substances and have to go through the withdrawal. Okay, that involves like physical, like you're becoming desensitized to pain. Think about impulsivity, like people who engage in impulsive actions, childhood physical or sexual abuse, right? Witnessing or engaging in violence, tattooing and piercing. I mean, do you know there are people who get their eyeballs tattooed? Have you seen that? Like people actually get their eyeballs tattooed, and then you have to think about like the amount of physical pain they have to tolerate. People who engage in multiple surgeries, people who have multiple accidents, serious drug abuse, engaging in prostitution, like that's a very, like you are going in really dangerous situations. And psychiatric conditions like eating disorders like Laura identified and borderline personality disorder. So what do you think about this so far? Before I move on to the next part, well, what are your initial reactions to this whole concept?
To me, it kind of makes sense. It's somewhat not self-explanatory, but it makes sense because again, looking at this presentation and the population we work with, like it makes sense. There's a correlation, I think, for me at least.
Yeah, thank you for sharing that, Willie. I appreciate it. Yeah, that it kind of like makes like logical or intuitive sense, right? That people who can tolerate more levels of pain are and also have the desire to die, right? So I work at a group private practice, RICBT. It is the biggest practice in the state of Rhode Island, and I serve as the patient safety and risk management coordinator. And sometimes I'll have a clinician reach out to me and ask me, okay, well, my client is is very upset. And I talk to the client, and turns out the client is terrified of dying. I mean, the reason that they're so anxious is because they are terrified of dying. And that is someone that would automatically be at a much lower risk. Does that make sense? So we have to think about like how much desensitization has occurred to pain and provocation. What we see is that there is increasing lethality and intent in people who have a history of suicidal behaviors. And that is why when you do a risk assessment, you have to always assess for, is there a history of suicidal behaviors? Does that make sense? Because somebody that has a past history is at a much higher risk. Multiple attempters have more intense suicidal symptoms than first-time attempters, and past behaviors increase risk for later suicidality, even when we statistically control for everything else. And think about any activity that allows people to get used to pain and provocation, all right? Like when I worked, I lived in Ohio, once again, I have no idea why I lived in some of these states like Ohio, Missouri, Kansas. But I lived in Ohio, and I had this patient who would drink excessive amounts of alcohol and pass out in like frigid weather to the point that he had, his like toes and his fingers had been amputated from the frostbite. And you have to think about the pain tolerance that goes along with that. Interestingly, what they have found that people who are suicidal have higher pain tolerance, they have less intense appraisal of the pain, and they have lower physiological reactivity to pain than controls. And we have to keep in mind like the self-harming behaviors and the suicidal behaviors are something that are seen not only in human beings, but in primates. They're actually seen in dogs and other animals also, is where people will like hurt themselves physically. Any questions so far? Are we in the mood for another funny clip maybe? Yeah. Let's do this. Okay, let's see. Do we want to do a dog again, or do you have a preference?
No preference.
No preference, okay. All right, let's do this. Do you see the screen? Do you see the cat screen? No. Okay, hang on. All right, give me just a second. Do you see it now? Okay. All right, so see that it was not as funny as the Denver the Guilty Dog video, but this is what we're going to do. We are going to take about like 5-10 minutes. Tanya, can you hear us?
Yep.
Is there a chance we can like do breakout rooms?
You should be able to. I'm not host anymore. I'm going to just pause.
All right. Anyone want to share like how what we learned today about the acquired capability for suicide? How might that impact your clinical work, and how that might change like the assessment or the treatment that you provide?
I can definitely share. So my coworkers, Erin, Sarah, and I, we work in Kent County, which also covers North Scituate, and other areas that are very, I would say, less densely populated than, say, Warwick. So, such as Coventry, West Greenwich, and Green. And usually, when we do formulate a safety plan with a client, we try to have the parents lock up any sharp objects. So, especially in the less densely populated areas, you find a lot of gun companies. I feel like I'm driving by them all the time when I'm going from North Scituate to Coventry. And a lot of our clients in those areas are armed. So I would probably include firearms, locking the firearms up and keeping them safe in the safety plan as well. And then additionally, just trying to make a better connection with male clients, because I know that I've ran into this, so I'm sure others can, but sometimes gender identity can really hinder a relationship with clients. For example, in Kent County, we have a couple of male clients who refuse to meet with females, but with our male tracker leaving in a couple of weeks, it'll just be females. So really trying to foster a relationship with male clients is going to probably become quite a large priority. So, you know, they feel safe sharing information with us and having a better relationship with us as well.
Thank you for sharing that, Jenna. I think those are such good points. Absolutely. Yes, I think like being more cognizant of like means restriction. And like what you said just reminded me of something. There's Rhode Island has the ARPA law. Does anyone know that? Extreme risk protection order. Okay, I'm just going to send the link to you. I believe it was Gina Raimondo passed the law back in, I want to say June of 2019. I think it was June of 2019. But basically what the extreme risk protection order law says that if you are, as a clinician, concerned about a client's safety, especially when it comes to firearms or any other lethal means, you have the right to reach out to the local law enforcement agencies who can initiate a situation where the individual's guns or other lethal means are temporarily taken away from them. All right, and that's something to kind of like, just going to find the link here. Okay, I'm just going to put that in the chat box here. So let me know once you received it. And if you click on the link, you will see that it has more information. I mean, of course, there are more nuances to the law. And I'll give you a couple of minutes to review the link. Did everyone get the link in the chat room?
I don't see the link.
Say that again. I heard someone.
No link is in the chat room.
Who is this? I can't.
It's Andrew. There's no link in the chat room.
Oh, okay. Oh, you know what? I think I sent it only to Tanya. I apologize for that.
I just forwarded it, Prachi.
Oh, thank you.
You're welcome.
Okay, do you see the text from Tanya? Do you see the link from her now? I'm going to have you click on that, and that kind of like talks about the extreme risk protection order law. Basically, like it goes back to the point that Jenna made about like the importance of taking lethal means away from people. And I know that can be a tough decision sometimes, especially because like guns could be a part, like if someone is in the military or things like that, guns could be a big part of who they are. Any other reaction? Jenna, thank you so much for sharing your impressions. Anyone else want to share?
Well, just going off that, the whole firearm thing, I work in South County in East Bay, and we actually had a client whose foster father had guns in the home, and he had multiple guns that they disclosed to us. So we had to really monitor what was going on, make sure that they were locked up, and essentially work with DCYF to make sure that they had known that there were guns in the home, and make sure that the client wasn't at risk at any point of being able to get a hold of them, or, you know, dad giving him, which turned out dad actually had it locked up. Nobody had the key except for dad, and there was a camera on the gun case.
Okay. Thank you for sharing that, Andrew. And when you speak, there is like a bit of a lag. So, but yeah, thank you for sharing that. And I'm glad you brought up the point of involving DCYF. Like if an adult has access to lethal means, and if they refuse to lock them up or store them appropriately, like not taking the ammunition away, or like storing them away from home, or locking them up, or like whatever needs to be done, you can actually involve DCYF, because that does constitute as abuse or neglect, or more like neglect. I appreciate you mentioning that. Anyone else want to share their perceptions before we move on here?
For me, the more information, the better, because I feel confident working with clients that have SI statements, but I know it can go from okay to legal nightmare in seconds. And so just covering all bases, because I know if, God forbid, something happens and someone does follow through with it, the attention's going to go on the worker right away. And I know it's not meant to be like that, but it's a safeguard for everyone. So just making sure you, like myself, covers every single thing that can be thought of to just help that person.
Absolutely. So, I mean, Laura, you bring up the point about kind of like liability, right? And I think like as clinicians, there is definitely this pressure. Like not only do we want people to live, but we also do not want to be sued. Like we don't want to be held liable. So I think that's a very important concern. And I think I appreciate you mentioning that. I think that would be a good segue into the next section. So with regards to suicide risk assessment, like when we document, it's important to kind of keep in mind, like what is the psycho-legal standard and what we are required to do. It's our responsibility to gather information related to risk factors, protective factors, and warning signs. Like the risk factors and protective factors we talked about. Also ask more information about ideation, intent, like what are the chances you're going to act on this plan? How much planning have you engaged in? What are your reasons for living versus dying? And based on this information, that you make a clinical judgment about like what needs to be done. So I guess what I'm trying to say is that having worked with clinicians who have been sued for loss of client, is that when the defense attorney, when the attorney of the family, so that's typically the family's attorney that will sue you if you did lose a client, what they're looking for is that you gathered all the information that you were supposed to, you took all the steps that you were supposed to, and that was informed by some of the recent advances in the field, and that you care about the client, right? And even that in that situation, even if you do lose the client, the chances are pretty good that you will not lose the lawsuit against you. Does that make sense? So it's our responsibility to gather comprehensive information about these things that are listed on the slide, and then to make a formulation. And that formulation, like you can decide that I'm going to either discharge the client to their home, or they could go to a partial hospitalization program, or they could go to an inpatient program, right? And whatever that decision is, that is informed by the assessment that we have made. The questions that I ask for is like, how likely are you to act on these thoughts? Like, how likely are you to, like, what are some behaviors that have you engaged in? Like, have you acquired guns? Have you acquired medications? How much rehearsal have you engaged in? Like, have you been like rehearsing even internally, like in your mind, or have you been rehearsing in terms of like behaviors, like certain things? Like, have you been planning? How much planning has engaged? How do you feel? Like, what happens internally for you when you are in that state of crisis? Like, what happens to you? What are some things that make you feel protective? Is that your religion? Is that your faith? Is that you have dependent children? Sometimes you work with someone that engages in suicidal behaviors only when they're under the influence of substances, when there are stressors present. And what are some of the static risk factors? Like, is there a family history of sexual abuse? Is there a family history of suicidal deaths? And those are the questions that we really want to ask. We are going to look at two of these approaches before we take a break. So the first approach is called ISPATH-WARM, which is basically an acronym for the warning signs. So you can actually buy these coffee mugs that have the ISPATH-WARM acronym on the inside, so you can do a risk assessment while you're drinking your coffee or hot chocolate or tea. I find that pretty interesting. But some of the things to look out for, the warning signs are, is the person reporting ideation? Has there been recent substance abuse? Do they feel purposeless? Do they feel anxiety and agitation? Do they feel trapped, hopeless, withdrawn, anger, reckless, and are there mood fluctuations? So these are the warning signs to look for, and these are different from the risk factors. So risk factors are factors that increase the chance. The approach that I love the most is the case approach. And I sent an article. I don't know if you had the chance to review that article that I sent. But the case approach talks about people who have the most serious suicidal intent probably are the ones who withhold it the most. Does that make sense? Can you think about it? Like, people who have the highest intent are probably the ones who are withholding it the most, generally speaking. It doesn't have to be always the case. So when we ask people, like when we want to assess what their real intent is, we have to consider that it includes both the stated intent, right, like what the person is telling us, the reflected intent, which is reflected through their actions and inactions, and the intent that they are withholding. Right? I think we have to be really sensitive when we do a suicide risk assessment. The way I think about it is, if someone was doing a risk assessment on me, they would walk into a room and ask me, what is the most shameful thing I've done? How would that be for me? Right? And can you see why it is such a taboo topic and why it is so difficult and challenging to be completely transparent about this topic? So Christopher Shea gives us like 7 techniques that I'm going to talk about. Did you get the attachment that I sent? Like, it's the appendix from this book that kind of like provides an overview of the 7 validity techniques. The first technique that he talks about is normalization. And what this basically means is that we normalize, not that it's normal to die by suicide, but it is normal to have these thoughts. Does that make sense? Like, how many, based on information that we have discussed today, how many people in the general population have had thoughts of ending their life?
Well, it's like you said, it's like when you had it's kind of like the F-it theory where, like when things get really bad, you just think like, like, oh, I just don't want to be here. I don't want to be in this situation, but it's there, like a lot of people have those thoughts.
Absolutely. Yes, thank you, Adessa, thank you, yes. So a lot of people have those thoughts. So one of the things that I want to normalize is that, you know what, I've heard this before. Like, imagine going to your doctor's office, like with the broken arm, and your doctor says to you, I've never seen this before. How would that be for you? Like, I've never seen a broken arm before. Like, you are the first person ever to complain about a broken arm. I don't know what to tell you, right? So that the thing that I kind of like communicate to people is sometimes when people are as depressed as you have been feeling, they find themselves having thoughts of killing themselves. Have you been having those thoughts? Right? So I'm kind of like normalizing their struggles. There's a lot of shame surrounding this. With everything that you have been going through, have you been having thoughts of killing yourself? With all of your pain, right? So I'm hearing that there's a lot of emotional pain. Have you been having any thoughts of killing yourself? And we don't want to use the word commit suicide. And what would be the reason for that?
Doesn't that go with like how you were saying where there's a means where some people are just thinking of it, and then there's those who are acting. So committing is more like committing to the idea of doing it.
Not really. Like, can you think about the word commit and like the connotation it has? Commit implies kind of like committing adultery or committing a crime. Does that make sense? Like committing, like you're committing a crime. Like, so you're committing suicide. So the politically appropriate term is death by suicide. So we want to stay away from the word commit. The behavioral incident technique in the past, when I was being trained, I'm going to date myself with this information. When I was being trained, there was this assumption that if we ask people about their thoughts of killing themselves, they are going to kill themselves. You know what assumption we have today? If we ask people and people answer yes, we have all the information we need. All right. So what I've seen clinicians do, and I teach in a graduate program, our students go on to become clinicians in the state. I've seen that a lot of times students will find out, okay, that the patient is thinking of using one specific mean. Let's say they're thinking of using guns. All right. And immediately the student will stop asking questions. So what we really want to do is we want to ask more and more specific questions. All right. Let's think about this. There could be two people who are thinking of using a gun. All right. One person has a gun sitting in their nightstand and they said, you know what, I've been thinking about using it. The second person, person B, could be saying that, you know what, I was sitting with the gun inside my mouth for 2 hours. Do you think that there is a difference in the level of lethality of these two people? Technically, yes, right? So just having information about the gun alone is not sufficient. We really want to find out more information about what did the person do with the gun? What did the person do with the medications and things like that? So we want to ask a series of questions, a sequence of questions. Any questions, any comments so far? The gentle assumption technique is basically assuming that the client has already engaged in the behavior. You know where this comes from? Interestingly, Dr. Shea talks about it. Most of the research on this comes from research on masturbation. So they did a research study, a national research study in the United States, and asking people questions about whether they masturbate. Okay, so they asked like random people, do you masturbate? And guess what the finding of the study was? Nobody in the United States masturbates. All right. And the reason for that is the way we frame the questions heavily influences the kind of information that we get. Does that make sense? Like you ask people, like, how often do you drink alcohol? What do most people say?
Couple beers here or there.
Right, right. And how accurate is that for what we know about like the prevalence and the incidence of substance use?
Generally an underreport. People usually, when they do drink a bit more than just a couple of beers.
Can you repeat that, Trey?
Oh, I'd say that's generally an underreport. Usually when people drink, they drink more than like 1 or 2 beers.
Right, absolutely. Right. So like what you do in the substance abuse field, or when you're trying to ask questions about something that is very sensitive, is that you have to keep in mind that people are minimizing. So what other ways have you thought of killing yourself? All right. And so what that basically does is that basically assumes that the person has already engaged in this behavior, like they have already thought of other ways of ending their life. After the person has responded no to that question, we go on to the next question, which is the denial of the specific, where you ask people questions about specific methods. Like, what are the most commonly used methods? And you can go to the Rhode Island Department of Health website. They list all the common methods that are used in Rhode Island. What are the most commonly used methods? Overdose, yes, Michaela. Gunshots, hanging, jumping are the most common methods. So what I'm doing in the denial of the specific is I'm asking people specific questions. Have you been having thoughts of shooting yourself? Have you been having thoughts of jumping? Have you been having thoughts of hanging, right? And the idea here is not that I'm introducing new methods to people. Does that make sense? Like, I'm not asking people like, are you allergic to cats and thinking of sitting in a small room with like a dozen cats, right? Like, that's a very unusual method. So I'm asking questions about the specific methods. Once they have denied all of that, we ask the catch-all question. We have talked about a lot of different ways that you have thought about killing yourself. Are there any other ways that you have thought of that we haven't talked about yet? All right. And do you see, like, I'm kind of like, if the person says no, I'm just like not stopping there. And the last one that is my favorite method is symptom amplification. And I'm going to use the whiteboard here to illustrate that. So what we do with symptom amplification really is, like, think about this like as a graph, like the x-axis and the y-axis. Do you see what I'm drawing here? All right. Most people, we ask them, how often do you drink alcohol? They'll say, I have a glass of wine on Christmas Day, I had a glass of wine on Thanksgiving Day. All right. If we ask people, how much liquor can you hold? Can you hold a pint of vodka? They are more likely to report something in the higher range. Does that make sense? So if I ask people how much alcohol you drink, people are more likely to say, okay, 1 to 2 glasses of wine, all right, or 1 to 2 beers. If I amplify the symptom, if I suggest a much higher number, people are more likely to report something in the middle. Does that make sense? And I'm doing the same thing with suicidality. Is how often do you think about ending your life? Do you think about it 80% of the times, 90% of the time? And people might be more likely to report like 60 or 70% of the time. If I just frame that as like, how much time do you spend thinking about ending your life? They might have said just like 10% of the times or 20% of the time. Does that make sense? So any reactions to that?
It's probably the opposite. When I thought, I would think that you would undershoot it to not put that in their head. So it's interesting that it's actually the opposite.
Yeah. Yeah. Thank you for sharing that, Laura. Yeah, I mean, yeah, because generally, and you are not the only person, I think for the longest time in the field of mental health, we thought that having people like talking about things is actually going to make the situation worse, and research indicates it's just the opposite. People sometimes are relieved that we are talking about things with them.
I kind of like what we just went over, because it kind of helped me think again, like, how am I going to take this back to what I'm doing? Instead of just doing the assessment or asking the questions, it's not even about motivational interviewing where you just do an open-ended question. It's like you said, where you keep going and you dig a little deeper. And I like how you gave examples, because they help us, because as a tracker, I'm not necessarily like clinical, but that does rely on me if I have a client who I know is, who has ideations before, or, things like that, or is presenting signs right then and there in front of me. I'm not just going to walk away, or if I'm doing, like a scale or an assessment, it kind of helps me get more like context than just asking the questions and then walking away from it, you know? So it was helpful.
Thank you for the feedback. I'm so glad to hear that. Yes, I think historically, I think like most clinicians will just like ask one question. Like I will share this when I go to my primary care physician for an annual exam, like we all do. Like the thing that he will often ask me, you're not thinking of ending your life, are you? You have not been having those thoughts. And can you see how problematic that is? Like it's like if you, let's say if you are a person that is having those thoughts, it's going to be so much harder to share that, right? So yes, absolutely. And I'm so glad to hear that, Odessa. That is a really beautiful dog, Kelly. Is that a real dog? Is that a puppy?
Yeah, Benji. Yeah, he's a Bichon.
Oh my goodness. Is that a puppy?
Part of all my meetings. No, he's about 4, but he's like full grown.
Oh wow, he's adorable.
Thank you.
Just so cute. He looks like a stuffed toy. The animal.
Yeah, everybody says that he looks like a little, he looks like a doll, like a stuffed animal.
Yeah, so cute.
Thank you.
So let's cover a few more slides and then we'll take a break at 10:45. Is that okay? All right. I tend to kind of like give a lot of instructions about time because that's how I approach things. Is just a funny story. I took a few years back, I took a course at URI on master gardening. Hasn't even taken that course. I took a course, they teach you about like gardening and things like that. It's a really, good course if you're interested. You go for 16 weeks and then for 50 hours you volunteer at an organization, and I volunteered at a women's shelter. It was a very powerful experience. It was a great course, and things like that. But like the class would go from like 6 to 8:30, and at like 8:29 somebody would like ask like this really profound question, like GMOs, like what do you think about GMOs? And I'm like, does it really matter? Like, does it? It's like 8:29. Like, it doesn't matter right now what we think about GMOs. So I just want to be kind of like conscious of the time there. All right. So Tanya, thank you for. It's perfectly fine. Honestly, we are after the break. We are going to do some like work together as a group. So I don't want you to like keep trying.
Thanks, Prachi. Sorry about that.
No, it's not your fault.
Hopefully tomorrow it will be figured out.
That's fine. Okay, thank you so much. I appreciate it.
No problem.
So what Shay talks about is like when we do a risk assessment, we want to talk about what is the trigger in the situation. How has the person responded to a similar trigger in the past? What was their plan? How likely is it that they were going to be discovered? Was there a suicide note? Did alcohol play a role? Did hopelessness play a role? What stopped the person, if anything? Right? Like, were they discovered by the police? Were they discovered by their family? How were they found? And what were their attitudes and behaviors after being found? Like, I'll give you an example. A patient that I worked with in the past tried to jump off of the Newport Bridge. And when she was recovered, I saw her right away on that day. And her response was, I don't want to talk about it. Well, what do you think of that reaction? Do you think it's problematic that, go ahead, Devin.
No, I was gonna say, the reason why she may have not wanted to talk or disclose is because she felt hopeless enough to commit suicide, and because it didn't come to fruition, that she feels probably embarrassed, maybe. That's my guess.
Yeah, I think there's a lot of shame and there's a lot of embarrassment surrounding that. I would look at recent events, like I would look at what has happened in the last 6 to 8 weeks for the person. Why don't we want to go too far back in time?
It could trigger the person.
Absolutely. Good job, Willie. Yes. So anyone, like when you go to a psychiatric hospital or you go to, let's say, Kent Hospital, and they do an evaluation, things like that, you could be in a crisis and they ask you questions about, have you been sexually abused as a child? Have you been physically abused as a child or an adult? And can you see how that can be triggering to someone that is already in a state of crisis? And generally what research indicates that is past important, it absolutely is. Like if someone was a victim of sexual abuse as a child, it really is important, but it might not be super important in helping us make sense of the current crisis. We want to look at what was the most serious method that the person that used, what was the most recent method, and how many attempts that the person had. And I also want to look at like what is going on right now, and we'll talk about more like why this is important in helping people feel more mobilized. So this is kind of like the figure that kind of like depicts what I'm talking about. Is like I want to look at the immediate events, like what happened with the attempt, what happened right before that, what happened in the 6 to 8 weeks, and what are some relevant past events. But I really don't want to, like, if this person was like abused as a child, I really don't want to go into more details about that. I guess so what I'm saying is that it's important, like when people document, it's important to just saying, okay, this person does not have any suicidal ideation. We want to gather information about risk and protective factors. We want to gather information. Is this person having thoughts of ending their life? What planning have they engaged in? What are their behaviors, desire, and intent? And then making a clinical decision based on these two databases to create a formulation of risk. Does that make sense? And I know there's a lot of information being thrown at you in a really short span of time. Any questions or comments before we switch gears? Like the 7 validity techniques. And one of the handouts that I did email you talks about the validity techniques. It talks about the 7 different techniques and how to implement them. And if you wanted to learn more about, you can just like go to suicideassessment.com. That's a website where you will find more information about these techniques. The general rule of thumb, though, is to kind of approach it that it is a very taboo topic, and we want to approach it that way. Any questions or comments? All right, so how about we do this? How about we take a 10-minute break? Would that be okay? So I'm just going to, so it's exactly 10:40. How about we come back at 10:50? Would that be okay? We will wrap up the PowerPoint and we will practice one of the case studies, all right? And we'll go from there. All right, see you in 10 minutes. If you're ready, we'll go ahead and get started. Everyone hanging in there? I know it's a lot of information and it's a really morbid topic, so. All right, so this is a real picture from the Golden Gate Bridge. When you look at this picture, what do you notice about the nature of suicidality? What stands out to you?
To me, from the picture, it kind of reminds me of the saying, we all need someone to lean on. Because from what I'm looking at, I don't know if it's cops or whoever, but just him being held by those two is like a sort of somewhat relief, I guess. he looks at home, or like he just needed that shoulder. That's my interpretation from the picture. But I mean, I might be wrong, but that's how I
No,
interpret
no,
it.
there are no right or wrong answers. No, you're right. I mean, I think, yeah, I think you're very close to kind of like the answer is that, yes, I mean, we all need support. We all need someone to kind of help us navigate the crisis. And anyone else? Thank you, Willie.
When I was looking at it, it to me it spoke to like kind of some of the myths, and also some of the stats that you were talking about. Like you have an African American male jumping on a bridge, and that's kind of like a stereotype that you would assume like, oh, like most African Americans, you know what I mean, like don't like heights or something like that. Like I don't know, but or like you wouldn't assume that, you know, this young man would be jumping off, like when you were talking about how the woman jumped off the bridge, you know, and then you show a picture of the young male, so that was like in contrast to the other example that you had given.
Yeah. Thank you for sharing that, Odessa. Yes, I mean, you kind of like it makes you kind of like reflect on kind of the statistics and be mindful that the statistics don't apply to one single individual. Yes, thank you for sharing that.
It looks like they're supporting him the best they can, but they can't make him not do what he's gonna do. So they're just looking like they're just gonna support him until as long as they need to. But it doesn't look like they're trying to pull him up, just trying to like support him and talk to him out of it because he's a person with his own choices. That's what it looks like to me.
That's a really good observation also. And I think like that's something that I try to be mindful of when I'm working with someone who is having thoughts of ending their life, is that the client and us may not be on the same page, right? So in this situation, like the client might want to end their life and feel that if I end my life, everything is going to be much better, or like I will be better off dead, and that I might not be on the same page as a client. I think another important thing that this picture depicts is that people who are thinking of ending their life are ambivalent, right? And ambivalence is a good thing. Because if people were not ambivalent, they would already be dead, right? So, and the ambivalence is our foot in the door. So this is an actual picture from the Golden Gate Bridge, like I said earlier, and the person jumping off of the, trying to jump off of the Golden Gate Bridge, his name is Kevin Briggs, and the officer's name is Kevin also. And they are both actively involved in the field of suicide prevention at the moment. You can add them as friends on Facebook. The next approach that we're going to talk about is the collaborative assessment and management of suicidality. I'm not going to go in a lot of detail, just in the interest of time, because I want to make sure that we get the chance to talk about some of the two scenarios that that I would like to discuss later on. Ambivalence is our foot in the door. We all experience ambivalence, right? I mean, I don't know if this morning you woke up and I'm like, do I really want to go to this training? Probably not. I do. I have to. So ambivalence is just a part of life. And in the context of the suicidality, it's actually a good thing. This is a book that I highly recommend also. And here, the term is collaborative. We want to collaborate the treatment with the person, with the client as much as possible to make sure that we are all on the same page. Because I don't want to impose my beliefs. Like I might believe, not that I believe that, but I might believe that suicide is a sin or that it's not okay to do this to your family. But we have to respect, like somebody earlier, I think it might have been Odessa who mentioned kind of like the free will piece, right? Like people do have the right to end their life if they want to, right? If their life is unbearable. And so under the CAMS approach, what we really do is, the first thing we want to do is be very clear about the legal statutes. If someone says that they are an imminent danger to themselves or someone else, we have a responsibility to protect ourselves, or we have the responsibility to kind of like increase the level of care. I provide direction and guidance about the goal of establishing safety and outpatient safety. Why do we want to emphasize? Like, why? I mean, I'm not saying that I'm against hospitalizations. I'm definitely not saying that. Having said that, I will say this: there is no data that indicate that hospitalizations actually save people's lives. Why would we want to keep people outpatient as much as possible?
I think keeping people as close to being independent and living their life and figuring things out in their own environment is important, because if you just space all of their services inpatient and away from their own life, you're not really fixing the life that they live. You're fixing, obviously, what they're going through, which is important, but at the same time, like, they need to learn how to cope when they're at home, when they're living their life day to day. So if you keep that environment, it'll make it easier for that transition.
Absolutely. Great job, Michaela. Yes, absolutely. So the thing is, like, I can hospitalize and send someone to Butler for a couple of days, but what about their life is really going to change in those 2 days or 3 days, right? They're going to be discharged back to the same environment. They might be given medications that might not even kick in for a few weeks, right? Like, especially if they're prescribed SSRIs. And so what we really want to do is keep people outpatient as much as possible. I empathize with people, and when people are considering suicidality, I almost assume that I don't understand their pain. I always stay away from saying that I understand or I totally understand, because I don't, right? I don't know what it is to be at a place where someone is thinking of ending their life. I have no idea. But I always raise a question: is suicide in fact the best way to cope? Is this the best way to cope? And so what this approach basically looks at: first, we want to reduce access to lethal means. And the reason, the way I explain it to people is, okay, well, you are going through a crisis right now. Let's take away your lethal means. At the time being, you can have them back. It's not that I'm taking your guns away forever, but temporarily, let's get rid of them. I have people kind of develop a coping card or a crisis response plan. Like, what are some things that you can do in the moment when you feel this way? Who are the people that you can reach out to? And then I look at the drivers. Like, what are the drivers that cause the person to experience a crisis? What are the relational issues? What are the vocational issues? Self-related issues, pain and suffering. And I come with, like, problem-focused interventions. Like, let's think about this. If your husband is not treating you respectfully, what can we do? We can't expect him to change his behavior. But, like, let's come up with a plan. What can we do when he says mean things to you, when he is nasty to you? And one of the things I ask people is, like, not to own the message that they're receiving in an abusive relationship. Focus on the reasons for living. Like, what are some things that make your life meaningful? I actually have used this intervention. We'll talk about this a little bit later. It's called the Hope Box, where people actually put all the things that bring them a sense of hope into a small box. And we kind of, like, review that, like, okay, that you want to go to Italy, or pictures of your children and things like that. And the last approach that I'm going to talk about today is a cognitive approach. And I would imagine that everybody is pretty familiar with the cognitive behavioral approaches, where we kind of, like, try to challenge people's cognitions. Where we see the suicidal behavior is basically a problematic coping behavior, and it is seen as a primary problem rather than symptom of a disorder. And what I really like to focus on, what are people's reasons for living and dying? And the Hope Kit that I talked about is like a hope box. Like, what are some things that bring you a sense of hope that will make your life more meaningful? Because, like we said, it's not always possible to change the circumstances that drive the person to have these thoughts, or have the person to engage in these behaviors. So can anyone give me an example of what are some cognitive strategies? Have you heard of, like, what is cognitive intervention?
Is it trying to change your thought process and behavior patterns?
Absolutely. Good job. Yeah. So someone that is thinking that I'm a failure, I have no right to keep living, what would be a cognitive intervention?
Please, what was the question again?
So let's say somebody's thinking that I'm a failure, there is no point in going on, what would be a cognitive intervention for them?
Well, I think diving into those thought processes and figuring out where to redirect and how to cope with the feelings that come along with that.
Absolutely. Like, what is causing those thoughts? Let's look at like what are some times when we don't have those thoughts, and let's challenge those thoughts. Like thinking about you as a failure. That I haven't done my laundry in a week, does that make me a failure? Well, let's look at that more closely. I had this patient back in Ohio who had like bread with mold on it in the refrigerator, and for them that was evidence that they are a failure. And I always find it interesting what people see as evidence for being a failure. I mean, I would imagine that all of us in here have something in our refrigerator that needs to be thrown away, right? And at the same time, we don't take that to mean as evidence that I've failed at life or that I'm worthless. So I've said this before, identify the risk factors, identify the protective factors, document the risk assessment. Always ask, like, what was the event that led up to this USettle crisis? What was the activating event? It could be a fight with your spouse. It could be something that happened externally. What were the reactions to the event? What were the automatic thoughts? Like, what did I say to myself? And I create a timeline, a detailed timeline about like what that portrays or that reflects like how I was thinking, how I was feeling, and what were some of the behaviors that I engaged in. Also look at the patient's history. If someone already has a history of suicidal behaviors, they're going to be at a much higher risk. Always communicate that it makes sense that you're thinking like that and that you're behaving like that, and that makes sense that you're trying to reduce the pain. And I don't want to offer solutions to people. No, one thing that I feel pretty strongly about, and I know this might trigger a lot of discussion or debate in here, is what do you think about the police responding? And I'm like, I support what the police do and things like that. I don't have anything against law enforcement specifically, but what do you think about the police responding to a suicidal person?
I feel like it could potentially escalate the person or make them like more inept to possibly commit it, rather than having like a mental health professional or somebody who's trained in de-escalating the situations arrive at the scene first or with the police.
Yeah, I absolutely agree with that, Devin. Yeah. Just a few days back, I read about something called the Ebola rap. Does anyone know that? If you want to Google it right now, I'll just type it in the chat box. If you want to Google it, it's called, there are like some police departments, and once again, I'm like not complaining about police. I just want to kind of like make sure that that's not the case. But I feel like there is a lot of divide and discrepancy between like what police officers are often trained to do in the face of a mental health emergency.
Yeah, sorry, I didn't mean to cut you off. I just want to piggyback off what Devin was saying. I know we've had this discussion before. Me personally, I think for police, I don't think it's somewhat right for police to attend to how do you call it, mental health crisis. I say this because when we look down on what has been going on in America, most of the time the police don't go there to understand the patient. I'll give you an example. I think it was in 2020 when a Black man was shot right in front of his mom when he was dealing with, how do you call it, a mental illness. So most of the time, yeah, police presence is good or whatever, but they don't go there to understand what exactly is going on. As of if you're telling, if we have like a group of people that are trained in the police system to deal with such stuff like this, when they go, they're gonna assess the, how do you call it, the client or the patient and see what's going on. But a normal police won't have the patient. Well, some do, not all of them. I can't blame everyone. Some do, but thinking about it, police won't go and say, all right, he's a mental patient, so let me just let him do whatever. 99% of the time, they tend to defend themselves. And we've been seeing that every day in the news. So me personally, when I'm in a situation, I always try to avoid calling police. So, yeah.
Yeah. Yeah, I think that's a very great point. I mean, you also bring up the context, right? Like the social, cultural context in the United States of racism and sexism and things like that, which kind of like makes it even harder. Like if you are a person of color that is in a crisis, you have to worry about how the police are really going to respond to that. And Willie, I'm very much aware of the case that you're talking about is where I think you're talking about the scenario where the individual's mom called the police because he was having a mental health crisis and he was shot. Is that the case that you're talking about? Yes. Yes, absolutely. I mean, yes, I'm not saying that not all that all police departments are not trained, but I really think that having law enforcement presence in that situation probably does not de-escalate the crisis. Yes, I concur with that. And any other reaction? I think Willie brought up a very valid point there.
Just to piggyback off of like having trained people in the police department, I think the other part of that too is not just knowing what to do in a situation, but how we treat the person that we're trying to help. Like a lot of times when police get involved, it's more about community safety and personal safety and all of that stuff. And so you're not really thinking about the person's perspective. And I know like just from personal experience, I know some security people who work in psych wards and things like that, and personal stigma and like beliefs about mental health and stuff are still, like, everyone's human, and even like police officers are human and they still hold those. And so just being like knowledgeable about the people that you send in to help keep the community safe, but also be mindful of the person that you're trying to help in the situation, I just think is really important. And being knowledgeable about the biases that human beings hold in general, but also people in position of power is important. So I remember when I was looking up like different ways to set up like police and things like that, because I think restructuring is probably needed. I think it's a great idea to have just like a unit where there's like a specialized training so that they get like the bias training, but they also get like the suicide and the what to do when somebody's freaking out, because obviously if you're going through a mental crisis and people are trying to hold you down, you're going to freak out about it. It's a normal human reaction. So just more training is important. So that's just kind of
I completely agree. And I think I absolutely agree, Michaela, and thank you for sharing your expertise there. I will also say that this is an issue, like law enforcement is an issue, like the training, not only in responding to mental health crises, but also in responding to calls about intimate partner violence. I think that's a pretty significant issue also. Yes, if you get the chance, I would recommend that you Google the BolaWrap. I found it very disturbing. So just kind of like a long story short, the BolaWrap is like this device that is used, which is basically used to restrain what they call quote unquote a suicidal person. And I have a lot of problem with the way it is being advertised right now, and that law enforcement agencies are adopting the BolaWrap. I think there's a lot of problems with that if you want to watch the videos. Yes. And one of the things that I've heard from people, since the time I've been a psychologist, which has been a long time, I have hospitalized only one person. And the person really communicated to me, it felt like everyone was trying to cover their own ass rather than really being worried about my life. And I think that's probably true, that everyone is worried about liability rather than making sure that this person keeps living. When there is someone at imminent risk, we do have the right to breach confidentiality. I use that very carefully. I also think about like, what are some ways to reduce the use of lethal means? So we talked about ARPA law. I just want to talk about means restrictions before we switch gears. I'm being mindful of the time here. So these are data that I never share with anyone from this PowerPoint slide. I would never share that with a patient, that if you were using cutting, the chances of dying from cutting are 2% versus from suffocation or hanging, they are like 26% and 51% from firearms. But this is something just to be mindful of. These are like data that I would recommend that you kind of like monitor or like just note as you work with your clients. So some things to kind of keep in mind is that people who attempt suicide typically do struggle with ongoing mental health or substance use issues. Generally data indicate that approximately 94 to 96% of people who die by suicide have a mental illness. Can you guess who would be the remainder 4 to 6%? It's okay if you're not paying attention to the first part. So I said that about 94 to 96% of people who die by suicide have a mental illness. Can you guess who the remainder would be? The remainder is people, generally teenagers, who have high levels of impulsivity and have access to lethal means. Something to kind of keep in mind. If the individual does not have access to lethal means, we can increase the chances of survival. And over 90% of people who attempt actually do not go on to repeat the attempt. So that's something to keep in mind. One book or one person that I would recommend that you learn more about is Kevin Hines. I'm just going to type that in the chat box here. Kevin Hines is an individual. He wrote the book Cracked, Not Broken. And he's one of those people who jumped off of the Golden Gate Bridge and one of the very few people to have survived it. And he shares his story. If you want to like watch his TED Talk or on YouTube, like probably one of the most effective speakers I've heard. It's just like a very powerful and a very amazing story that I highly recommend that you learn more about.
So Prachi, sorry for interrupting you, but I was going to bring that up earlier in this training, but I couldn't remember the name of it. But I remember watching it because after the fact, he regretted even trying it. Like he said, like as he jumped, he automatically was like, "What have I done?" So yeah, it is a good documentary.
Yeah, I think that. Thank you for sharing that, Devin. I think the documentary is called The Bridge, if I remember correctly. But yes, it's a very powerful. Yes, he talks about as soon as he jumped off to the Golden Gate Bridge, there was like this sense of remorse about having done this. Yes. When we consider about when we consider about means restrictions, you have to consider how many people die by that method, how lethal that method is. Gunshots are always way more lethal. How irreversible the effect of the method is, how accessible it is. So medications like Benadryl or Tylenol might be more accessible, but not as many people die by suicide. And how acceptable it is. Can you think of like some other cultures where a certain method of suicide is more acceptable, but it is not in the United States?
I mean, this is just a long shot, but poison? Maybe not. Poison. I said this may be wrong, but poison in other countries possibly, or other cultures. I'm not sure.
Yeah, I mean, other countries, there are some countries, especially in Southeast Asia, where like ingestion of poison or insecticides or pesticides is way more prevalent. I grew up in India, like I said earlier. This is back in the 17th and 18th century. If a woman's husband died, she was expected to kill herself by setting herself on fire. And that was considered to be a socially acceptable means of dying. If you want to read more about the practice, I'm going to type it in the chat box. It's called sati, which is basically if your husband dies, you have to go sati, which means that you end your life by setting yourself on fire. I already talked about this, so I'm not going to get in detail about the patterns across different cultures, and Devin kind of alluded to that already. But always take people's means away. And I know like that can be against free will, like people should be allowed to own guns, people should be allowed to have the medications they want and things like that. But with guns, there are other things that you can do. There are some local police departments that will store for you. Some are there like gun places that will store them. I'm not a gun person, so I don't know much about guns. There are ways like you can take the ammunition away. That's one plan, and explain like the rationale for taking some of these steps. What this slide talks about is sometimes brief interventions, talking to people briefly after. Well, let me backtrack for a second. What research indicates that when people get discharged from a psychiatric hospital, they are at a much higher risk of ending their life. Can you think why?
Environmental shock. When you go from a place that's like heavily secured and like you have everything like kind of patted down for you, and then you go home and it's kind of like a shock to the system and like a reminder of what your life was like before you went inpatient.
Mm-hmm. Yeah, that's a good point, Michaela. Yeah. There can be a lot of shame and embarrassment about hospitalizations. So what research indicates that having just like brief contact with people following a hospitalization has been associated with really good outcomes. With regards to guns, what I suggest, and we already talked about this, there are gun shop, there's like shooting ranges, self-storage units, pawn shops, some law enforcement agencies. There are locking devices. I have some locking devices at home. If you ever need them, you can just shoot me an email. There are some people who are not allowed to store guns. And I just want to say that I'm not using the word illegal alien. I know it's listed on the slide, but that's like copied from the law. I think it's absolutely incorrect to refer to people as illegal alien. But that's a term that the law uses. But this gives you a list of people who are not allowed to hold a gun. It's like if somebody has been convicted of a felony, fugitive from justice, unlawful user of controlled substances, somebody that has been judged committed to a mental institution, illegal alien, which is a shitty term, but what they mean is like an undocumented individual, person that has been discharged dishonorably from armed forces, someone that has renounced their citizenship, someone that has been has a restraining order against them for intimate partner violence, anything related to domestic violence. With medications, I wouldn't take them home. I would get rid of them. Not really take them home and like flush them down the toilet. What I've done in the past is called poison control. I believe the Rhode Island Department of Health has a grant right now where they actually give you lock boxes. They're super expensive on Amazon. They're like $800 for a lock box, but they can actually control how much medication is dispensed. The last set of innovations is there is a lot of use of social media and apps for the management of suicidality. And I recommend that you take a look at those also. And these are some resources that I recommend. These are some websites that informed our presentation today. That is my email address. If you need to shoot me an email, you're absolutely welcome to at any given point in time. How about we do this? We have two, excuse me, I hope I don't have COVID. It's like you don't want to like sneeze or cough around people these days, right? It's like it's a taboo thing. So we have two case studies. How do we feel about, so one, how about I give you about like 10-ish, 15-ish minutes to work on this as a group? Do you know each other's phone numbers generally? Do you know at least one other person in this group?
Yeah.
So yeah, I know one other or two other people.
Couple other people. So there are people that you work at the same agency with. Can we have you work on like these two case studies? All right. I don't know if you see both of them on the screen. I'll give you a couple of minutes to jot them down to the relevant cases, relevant case information, and we'll go from there.
And Prachi, you know what? The handouts that I sent, I actually included both scenarios in the last page of the PowerPoint handout so that they could see them larger. So they'll have them there as well.
Perfect. That's awesome. Thank you so much. So how about I give you about like 10 minutes to work on this? What I really want you to do is apply the concepts that you learned today. All right. And think about like, what are some things that stand out to you about these case studies? And what are some things that you would do based on the information, new information you learned today? All right. So it is 11:24. I'll give you until about like 11:34 or 11:40. Okay. And I'm going to mute myself. I recommend that you do that also. So that, I mean, when you're having a discussion, not everyone is here. And I would imagine everybody has a PowerPoint. Is that correct? It was emailed to you.
Yep,
okay.
Everyone has all the handouts.
Okay, perfect. I'll see you here in like 14 minutes. about these scenarios? So let's look at the first case. Just going to put on the screen here. All right, so based on the information we learned today, let's talk about some things that stood out to you. What would be some of the skills that you learned from today that you can apply to this scenario?
My guess would be 911 immediately and then try to talk them down because the gun situation, the statistics are way higher that you put up. So I probably wouldn't try my best to talk them down yet and involve someone who's super trained to help me help him until rescue got there.
So just to piggyback off of what you said, so in my little group, we noticed that he's struggling with drug addiction and ended up moving back into his parents. So if he's suffering from a drug addiction, he's possibly already having trouble like thinking of things logically or rationally. So I was saying how when his girlfriend broke up with him, rather than being able to digest it healthily and think and like just ask like, you know, what is it that happened, and then like moving on and learning from it, he's at a heightened state, so he's just gonna get very anxious and question everything and like I guess like blow up her phone, whatever. And in seeing these behaviors, the parents decided to outreach a mental health center and urge him to see a counselor, and he refused. So he must be extremely, like it says, desperate or at wit's end if he's attempting to get father's gun, or he already achieved father's gun. And we were discussing like how it'd be uncomfortable to go out to the home and address it ourselves unless there was possibly a police force present in order to potentially back us up due to there being a lethal weapon involved.
I agree. I agree with what you and Laura have said. I think like the presence of the gun and like the desperation, right? I think like that kind of definitely calls for a pretty quick response to the situation. Thank you. What about others?
In my group, I think the issue that we were having was trying to decipher like where, like the first scenario didn't exactly give enough context as far as like where were we in the treatment plan? Like were we at the house after all this has happened and he's going like literally on his way to get the gun? Or are we talking about it after that happened? You know what I'm saying?
That's a really good question. So let's picture, I mean, because yes, I mean, James, like you identified the response that we give to him, the response that we have as crisis workers would be very different depending on if we are at this individual's home or if he's already at the hospital. So it sounds like our hands would be tied if we are already at his home and he's reaching for his gun, right? Yeah. Let's say that you were talking to him after the fact, right? After he's already on a psych unit. What would you want to say to him?
Oh, well, that makes it different. Because we were thinking, like, is he getting the gun right now? I'm not going to his house. You know?
Yes, absolutely. No, that makes sense, right? Because you have to worry about your safety also, and you have to worry about your safety first.
I mean, in that perspective, then you can go back and talk about, you know, maybe not everything, but just that specific scenario. Like, how did you get to this point? Like, what is going on specifically? I mean, obviously, I'm assuming he's told you the whole story about his girlfriend. So you can go into that and talk about, you know, try to get him to realize for himself what he can, like the fact that just because he broke up with his girl and she won't get back with him, that's not the end of the world. So like kind of like lead him into that thinking, in that mindset.
Yeah, and he might not be receptive to that right now, right?
Right.
We've all been through breakups, right? Where it's like, okay, and then you realize, well, you know, there is more out there. There's better There are better people out there, right? So, but in the moment, it can feel like so painful and so real. And it's almost like we have to see it as like grief and bereavement, right? I mean, it's kind of like a significant loss for Robert.
So, I just sorry to interject again. I just wanted to say that I was mentioning to my group as well that if we were doing like an after the fact like treatment plan type thing, that we would want to address his drug addiction first, which may be preventing him from thinking logically and rationally, and then be able to present him with the breakup so he can digest it in a better way, and move on from there, kind of like step by step.
I absolutely agree with that, because I would imagine that that's probably playing a role, and I would want to know if he was under the influence when some of this happened and things like that. Yeah. What about the other groups?
I mean, the way that I read the scenario, it's kind of tricky with the rehab thing because a lot of people who get addicted to drugs have mental health issues too. So I think having that dual relationship between figuring out where the drug started and kind of where his head was at when that happened. And the other thing was too, like, obviously locking up the gun so that he doesn't have access to them. And the other thing too, I was thinking, like, a lot of times when people are addicted to drugs, they go back home, like they're unhappy with their life, they stop going to work, kind of isolating themselves. Having that girlfriend might have been just like the final straw and like losing everything. And like maybe he was in a bad place. And so losing that girlfriend might have not have been the trigger for the gun, but maybe it was kind of like the last straw kind of thing. So figuring out kind of where his mental health is at and why he moved back home in the first place, even if it was drug addiction or if it was depression or if it was something else to cope with. I also think, like, obviously rehab's a good idea, and maybe like group therapy, because if you're living at home and you're kind of isolated and all of that stuff, like having a community of people who understand you, like even just like other drug addicts or even just like a grief counseling, like if he's really struggling with like losing that girlfriend, then it's not like a death in the family, but it's still grieving. So if you have people who are kind of going through that with you, it might make him feel less isolated since he is like back home and kind of not being an adult, maybe like he feels he might. So that's just kind of my thing.
I think those are great ideas also. Thank you, Michaela. Yeah, I think like making sure that he's less isolated, I think would probably be a good idea, especially to kind of overcome this loss. Anyone else? Yeah, so I think, yeah, I mean, increasing the support for this individual, looking at some of the drivers for his behavior. I would also want to see, like, apart from the gun, like, are there other means or methods that he has considered using? I would want to, like, stabilize him and make sure that he does not return to this level of crisis again. Yeah. Good job. Let's look at the second scenario, which is a child. What stood out to you and what would you do?
I think in the second scenario, we kind of just, it's a little bit easier compared to the first one. Not easier, but it's more of a mental health setting. So you can approach, and everything from like, all right, let's go back, you can control the pill taking, you can put the pills in places that way it's locked up where he can have access to it. And then find out exactly, I'm trying to think of what the scenario said, like why, like pretty much the same concept, like how did she even get to that point? And like work your way through that. You can have more of a conversation because she's thought about doing it, but she hasn't done it. So it's at the point where like you have to figure out, is she actually going to do it or is she just thinking about it?
I think that's a good point. I mean, kind of going back to the topic of ambivalence, like there's more, like there's a bigger room for intervention here almost, right? Because I mean, compared to Robert, like this individual is kind of like considering acting on it. Thank you for pointing that out, James.
I do think, our group talked about, with this kid, I do think this is someone that would benefit from services. I think, an agency that can deal with, maybe putting a clinician in place, talking about the SI stuff, an agency that can work on her with school, work on her, with socializing, getting back out with her friends, and maybe even performing some family sessions, because I'm not sure how, it's not like a kid could get placed in this situation, but, maybe, working towards something like that or getting her a safer environment where she can kind of flourish. And I do think family sessions may help with something like that. But I do think this is kind of like a perfect candidate for somebody that could benefit from services in some capacity.
I agree. Yeah, especially given that all that is going on at home. I mean, it sounds like there's a lot of stressors at home. So this would be a good person to kind of like, at least like receive additional support. I mean, there is no harm in providing additional support to a 15-year-old who has so many stressors going on at home. Thank you, Sarah.
We were also talking about well, in this one, she's much more revealing than in scenario 1, where he just was more closed down. And because in scenario 2, it says that she revealed to the guidance counselor, and she was willing to talk to somebody, which is a start. But also too, like kind of piggybacking off of, I think it was Sarah, what she was saying is also services too, maybe even helping the father, like for resources with dad. And then also too, maybe asking her questions more, because you were talking about like that pain and in association, and seeing like how the drinking and the fighting is affecting her. Is it directly affecting her? Meaning like, I know it says it's the parents are fighting, but like if he's drinking or other things happening, like when he's, taking the pain medication and drinking, things like that. So kind of exploring more into that to kind of gauge where she's at and how she's feeling with all these stressors.
Yeah, I think that's a good idea also. Yeah. Yeah. Yeah, and the more support, the better. I would want to know like how the parents fighting is impacting her. Do they fight in her presence, and like what happens? Anyone else? I know you were really thinking about lunch. You can be honest with me. I am too. So don't worry about that. You have my email address. If you have any questions, concerns, you are welcome to reach out to me. I really appreciated this opportunity, and it was great getting to meet you virtually and being able to have these like really rich discussions. And yeah, I really appreciate your undivided attention, and I appreciate your active participation. Yeah, feel free to reach out to me. All right. Well, I hope you have a great rest of the day. Tanya, do they have to complete an evaluation or something? I don't want.
I was just actually hopping on to put that in.
Okay.
Let's see where I minimized that document. Got it right here. So I'm going to pop this in the chat for folks. Let me make sure I have it to everyone. So it's just a link to the evaluation, and if if you could fill it out, that'd be great. If not, I'm going to resend it out with the materials for the next class you have next week, and I'll include this just in case folks don't get to it. But in any event, please have it entered before your next training. This way, you don't have a whole bunch of them kind of stored up where you don't have the ability just to really reflect on what it is that you have kind of been focusing on. Any questions? All right, excellent. You guys were great. What a great training. Thank you so much. And you know what? I realized I've been mispronouncing your name, Prachi. I've been calling you Kene, right? I heard you say Kene. So I'm glad to have actually heard you say it. So now that I'll say it the right way. Names are important.
No worries. I was once called Prachi. I will take anything over that. Trust me. No worries at all.
Excellent. Thanks, guys, and I will see you next week.
Okay, bye. Have a good day.
Take care. Thanks again.
Thank you.